My main theme here will be to help you understand addiction as a health condition, as a brain disease. That's why I always start out with an image of the brain. This is a PET scan on this introductory slide. That's a positron emission tomography. So that means a radiograph that shows the blood flow using radioactive sugar molecules to show what parts of the brain are receiving the most blood flow. And we'll talk about this a little more, but the revolution in our understanding of addiction comes from these kind of techniques that have been available for the last 20 to 25 years, because they really have given us a glimpse inside the skull that we never previously had. And so it helps us explain. Doesn't always help us change, but it certainly gives us a new way to understand these conditions and hopefully provide better, more humane, and more effective treatments. Now, of course, I'm going to talk about how drugs and crime are linked in meaningful ways. You all experience that on a daily basis. And a broad theme is that it's a combination of public health and public safety approaches that are going to work the best for persons with addiction. And certainly the community court movement and approaches are one of the proven techniques for addressing this. And I see these as part of the drug court models, a broader version of that, as a way to address these in a really proactive way that you all take for granted, but remains at the leading edge of thinking about how to put these together. And unfortunately is not all that commonly practiced around the country. So while it is for you all a regular practice, there's so many places that need to learn from your experience. I got a lot of data on how drugs and crime are linked. We certainly see it in terms of how common drug use is among persons who end up in the criminal justice system. I'm a little bit concerned in that our data around the disorders, what I think of as addiction, abuse, or dependence, among persons who are incarcerated, the data for that is a little bit old now, and I don't have any new studies that are being conducted by the National Institute of Justice, or BJA, on this topic, but I hope we can inspire them to refresh our data to see if there's been a big shift. The data from about 10 or about 12 years ago showed that about half of jail and state prison inmates have a diagnosable drug-related condition, and a little bit lower in the federal system. So even if it's gone down a bit or has changed, it's still a very large percentage of those who are incarcerated have a substance use condition. Now, when I said I want to think of these as a public health and public safety in combination, well, why can't we keep them separate? Why can't me as a physician run my treatment program and just do a good job with my patients, and then we would all do fine? Well, the problem is, all by ourselves, a public health approach often suffers from attrition, and particularly for the very high-risk individuals that you all deal with, that's a problem for public health in the long run, and certainly for public safety. There's a real issue with recidivism when public safety purely uses incarceration and other criminal justice sanctions and doesn't think about offering health services or behavioral health services that we're focusing on. By putting these together, you can include community-based treatment, as we were just hearing about, the opportunity. I was fascinated that even in somebody who could just take time as served and plead guilty and move on, they were more interested in erasing that record by actually going a little extra and doing a little something. I mean, it's not very much to be assessed, but it is something. So it required something of those individuals, and so many of them took them up on that offer. I think that speaks to some of the assumptions that are inherent in our systems, that we assume that people aren't that interested in getting benefits for themselves. But if you make it a clear case, our patients or your clients will take us up on these offers. We need the advantages, though, that the criminal justice system has in terms of close supervision and the ability to provide some consequences for noncompliance. Now, some of the key principles in terms of the drug court models and others are that those consequences are minimal, so they're measured, but they're also swift and certain, so that they become a predictable response. It's kind of like if you were, where do we use behavior every day? We do with children, we do with our pets. Imagine if you were trying to train your child not to cross the street in heavy traffic, and you only occasionally reprimanded them for running across a 4-lane road. Why would you be surprised then when they didn't learn very well? So that the sanctions, in that case, a quick yelling at them, needs to be immediate but measured for it to have an impact. If you overdo it, then they don't even remember what they were being punished for. All they remember is the punishment. So it doesn't accomplish that sense of fairness that has to be part of this process. All right, that's my sort of theoretical approach. Now we're going to move into where my institute, the National Institute on Drug Abuse, has been focusing on this. Now we're the health research guys, and mostly we focus on supporting research at universities and institutions all across the country. We support most of the world's research related to drug abuse and addiction. We sometimes pull this together into basic principles document, and I'm really pleased that one of my colleagues, several of my colleagues, but under the leadership of Radonna Chandler, who worked at NIDA for a number of years, developed a booklet called The Principles of Drug Abuse Treatment for Criminal Justice Populations. And it starts out emphasizing that thinking about addiction as a neurological process, as a brain condition, is a key part of rethinking the treatment. Now, it has a number of other principles, and I'll go through a few of them, but I encourage you to take a look at this, because instead of doing just a summary of just like, well, what one treatment is best for this particular condition, it tries to distill the basic concepts that will be useful for everyone dealing with these complex learned behaviors. Now, one of our principles that we focus on is that addictions are a product of both your innate biology, your predisposing risk based on the genes that you did inherit from your parents, but in combination with the environment. And the environment is thought of in very broad ways, and I'll come to this in just a moment. But it's that combination that produces addiction. But it's important to think about this as the environment and these mechanisms as existing all across human development. So there are risks that change you early in childhood, whether that's exposure to early child abuse and neglect, that change the brain in important and now unfortunately measurable ways that can put you at higher risk. And that's some of the most cutting edge work that we're still trying to figure out. Is we know it puts you at higher risk, some of these early childhood experiences, but why that would be is yet to be fully explained. What I have for you are some of the graphs that show the brain developing across adolescence. Drug addiction, for the most part, expresses itself first during the teen years. There's something about teen years that puts individuals at exquisite risk for trying all sorts of risky things, substances being one of them. And why is that? Why is it that the teenage years are such a high-risk period? Well, we think some of this has to do with brain development, in that the parts of the brain that develop during so early in the teen years, are the reward structures, are the emotional centers of our brain. The parts that are the last to develop are in the front part of the brain. What's in the front part of the brain? Judgment, decision-making, how we decide how to operate in the environment and what we decide to do. So what you have is a brain that is primed to respond to novel, exciting, stimulating phenomenon that doesn't have the brakes that develop later on in terms of judgment and decision-making. Now, I'm so excited because now we have neuroscience to help show this. I do believe that the insurance industry has known this for a very long time. When you go to rent a car, it's kind of hard to do it until you're 25 years old. They didn't need a neuroscientist to tell them why, but now I can help explain it through understanding brain development that continues at least until the ages of 25. I will suggest that certain kinds of learning and brain development happens for many years after that. And I hope it will continue for at least another 30 or 40 years, because we always want to be continuing to learn and change our brains in important ways. Now, I mentioned that the environment is not something very simple, and it cuts across a number of domains. And this is how we think of what influences the risk for drug abuse and addiction. Whether that is the family and peer environment, of course, that's most important early in life, but we think about neighborhoods and communities. Even the laws, policies, and culture are part of the environment. Some of those are more malleable than others. I can't change your genes. I can change the way parents may interact with you. We can do a little bit about your peer group. You all often try to shape the peer group that your clients are exposed to, sometimes with more success than others, but you're trying to give them tools to shape the environment as a way of improving their health and outcomes. So that's when we think about the environment, think about this notion of a gene-environment interaction, biology and environment. The environment is complex. It may be the lead toxicity that you're exposed to, but it's also the neighborhood factors, the friends, the peers, the school environment. All of those play a key role. Okay, one question I get all the time is drug addiction inevitable? And of course it is not. All of us know people who drink sometimes and not terribly often to excess. And we don't think of them as having abuse or dependence or addiction to alcohol. So that same pattern is true with all the different substances. On the other hand, almost everything that humans take for its intoxicating properties can produce a dependence or an addiction-like syndrome. Even cannabis, if I were giving you a lecture on marijuana, on cannabis, that would be a major theme, is that something that the public and many thinks don't produce addiction. I've taken care of lots of patients who struggle with their cannabis, their marijuana use. Can't seem to stop using it, want to, and seem to be unable to change their long-term pattern of behavior. And yet that's something that the public doesn't think is much of an issue typically. Certainly, but so it's sort of two messages. One is that these patterns can be ubiquitous to all of the different intoxicants, but that they're not universal. And so that there are many people that use that either don't like it very much, so they don't develop that learned behavior that ultimately leads to addiction, or for one reason or another, their life course takes them away from that environment, or they outgrow it. That's a very typical pattern. Certainly heavy use is a big predictor of progression, and early onset is a real predictor of progression. So those of you that work with juveniles, we need you to be paying attention to providing either drug treatment or drug abuse prevention for those kids who are at most high risk of developing a lifelong problematic pattern. All right, I've talked a little bit about human development. I want to talk a little bit about just one or two examples, one example from the neuroscience area about an environmental influence. This is an amazing study that uses primates. So these are monkeys in a laboratory setting in Wake Forest University in North Carolina. And they stress these animals by putting them in individual cages. That's extraordinarily stressful for primates, including human beings. Being isolated is not how we are designed to live or to exist. And what they found is when they looked in the brains, and this is a picture of dopamine activity. So it's one particular brain chemical in the brains of these primates when they were housed individually. And you see the eyeballs on top. What you're looking at, those bright areas in the middle, are the reward centers of the brain, nucleus accumbens area, basal ganglia. This experiment then put them into a group housing. What that means is they were in a small troop, so there were 4 or 6 creatures in a slightly larger setting, and they arrayed themselves in a social hierarchy. So some became dominant. So what that means is that they eat first, they get groomed by the other creatures more, and they win fights. So in that case, what we saw was their brains changed. That alone, I found pretty astounding, that the social setting can change the brain biology in now a measurable way. Now, how come the drug addiction and drug abuse people were funding this study? That's because when we looked at the propensity to self-administer cocaine, those who had low dopamine brain levels, low dopamine receptors, found cocaine much more rewarding and reinforcing. They liked it a great deal and worked very hard to get their dose of cocaine. Interestingly, we see some of this showing in human studies. Now, of course, we're not going to do the experiments in humans, but we can study this in terms of natural variation, in terms of social support and their level of dopamine receptors. And we see a very strong correlation between more social support, that's our version of dominance or social goodies that you get from a group, is associated with a healthier brain dopamine system. Very interesting that there may be differences that could be shaped by the environment. It tells us the potential value of prevention that'll shape the family and neighborhood environment of individuals, so they're less likely to use drugs later on. Okay, we know that these genetics and the environment interact with one another. This is from an amazing prevention trial in Georgia, the Strong African American Families Study, Gene Brody and colleagues. And I'm not showing you the prevention part, but this is sort of one of the key lessons, and it's worth bearing with me as I walk you through this. What you have are two groups, those that had low-involved parents and high-involved parents. These are teenagers, so these are sixth graders, 11, 12, 13-year-olds, that general vicinity. And so those are the two groups. In pink, they have a low genetic risk based on this particular variation in their serotonin system. But just take the pink bar as the low genetic risk and the blue bar as high genetic risk. So what we see is if you have no genetic risk, so the low risk, those are the pink bars, whether your parents are super involved and supportive or not doesn't really predict whether you're going to go on and be a drug user. But for those that have low involved parents, so a high-risk family environment and the high-risk gene environment, their risk of getting involved in drugs as they matured over the next couple of years was markedly increased. We can change, at least to a degree, the way parents interact with their teenagers. There's some wonderful interventions that have a prevention effect by helping parents be more effective with their 12 and 13-year-olds. Yes, parents can learn. But this is the underlying principle in that it may be particularly valuable for those who have the highest risk. And that's what some of the latest science is beginning to teach us about the way these factors interact with one another. Now, I started out by describing addiction as a brain disease. One way to think about this that I highlighted even at the very beginning was that we can now measure brain differences in the persons who have brain differences in the persons who have addiction and those who don't. That's just like we kind of take for granted that radiography would be useful for heart disease. You see that on top. We can distinguish a disease versus a healthy heart. Well, actually, we can now distinguish on a large-scale basis, not necessarily for individuals, but on a large-scale basis, the difference in brains between, in this case, a cocaine abuser and a non-cocaine abuser. You're looking down at the head, and you see less blood flow in that frontal region of the cocaine abuser compared to the somebody without that cocaine, that problem related to cocaine. So some of the work has suggested 4 major circuits that all surround the dopamine system, at least as important in the onset of drug addiction. These involve things like reward and reinforcement. If drugs didn't feel good, didn't provide some pleasure, you probably wouldn't use them a second time, or a third time, or a 300th time. So that reward and reinforcement is essential to the start and the onset of drug abuse and drug addiction. And we can now understand which parts of the brain are involved in that. It's not just the reward, that pleasure, or that incentive to use, it's the link of that to memory. And I'm going to show you this a little more because this is sort of some of the core features of addiction in that there's exquisite memory for pleasurable activities. We are designed to remember very well something that gives us pleasure. We actually aren't quite as good at remembering painful stimuli. Those tend to fade, but pleasure sticks with us like glue. It's fascinating. And if drugs are what gave you the pleasure, that's a problem because it means your memory formation is around something that's ultimately going to kill you, but yet you still remember the positive aspects. All right, the third part relates to these frontal lobe function, the prefrontal and anterior cingulate gyrus, so these frontal lobe areas that are involved in inhibitory control, in what some describe as the brakes on behavior. You know, if you have the drive coming from feeling good in the reward system, we have the brakes put on by the frontal lobes. We also have motivation and drive as well in part of the systems in the front part of the brain. And these work together to produce the onset of addiction. Now, the continuation may involve some other brain systems because it turns out once people are in a fully addicted pattern, they're no longer necessarily responding to wanting to feel good. They're often responding to not wanting to feel terrible. So you're no longer being motivated by that sort of initial intoxication and reward. Now you're motivated by not having withdrawal, not having misery. And that's a little different process in terms of the brain systems. But this is enough of a lesson for 3:30 in the afternoon. I told you I want to highlight the memory circuits for just a moment. People, places, and things are the words we get out of 12-step programs, reminding us of the high-risk situations that my patients, your clients, have to figure out how to cope with over time. And some of the research has shown that we can now measure things like dopamine release when there's an exposure to something that is a drug cue. So if you show a nature picture versus, in that case, cocaine snorting picture, the cocaine snorting picture will produce dopamine release in a cocaine addict. The nature picture does not. This is a fascinating study out of Wisconsin that did something similar. It used instead of that, it's a slightly different technique. This uses MRI techniques to look at what parts of the brain were activated when shown a cocaine film, so those typical pictures. And they showed these 3 brain regions that showed more activity, more blood flow, when shown those cocaine cues, and they produced reliably a craving or an urge to use. The persons that don't have a cocaine problem really don't show any activation in those systems. If you haven't used a lot of cocaine and developed a memory for how pleasurable it can be, then you see a picture of a rock of cocaine and you don't think much about it, and it doesn't produce that automatic craving or urge, the way a pastry will produce an automatic craving or urge for most of us. Interestingly, what they did in this study, they did 2 parts. They first showed the cocaine cues, and you see a nice difference between the cocaine users and the controls, the comparison individuals. They also showed erotic pictures. So sexually explicit pictures are interesting to pretty much everybody. I mean, you may be horrified by some of it, but you will be interested. You will notice it. But I want you to see 2 things on this. The persons who were addicted to cocaine had an excess activation from the cocaine cues, but they had a diminished activation to the erotic visual stimuli cues. So that means, as a treatment provider, I have 2 jobs. I have to help people figure out how not respond to cocaine cues in the environment, and I have to help them figure out how to respond to things that should be pleasurable, either through long-term learning or a chance for their brains to heal over time, so that this happens over months or years, but that's sort of 2 jobs that we have in treatment. Now watch this one. Oh, did you get that? If that had been a picture of rock cocaine and you were a cocaine addict, guess what? Even that super fast flash would have been enough to give you a craving, and you wouldn't have even quite known why. Wonderful work coming out of UPenn that showed that even those really rapid photos, too fast for conscious recognition, can produce a reliable craving and an urge to use. And that's because the wires from our visual stimuli, from our eyes to those midbrain parts, are extremely hardwired, faster than to the conscious parts of our brain, to the front parts of our brain. We're going to skip that. What I want to sort of highlight for you, I've mostly focused on memory because I think that's a really key message here. But there are other parts in terms of how this dopamine system is related to diminished control, diminished functioning of the frontal lobes, so excess reward and reinforcement and diminished frontal lobe control over behavior, but that memory formation is at the center of it. And these are disrupted in addiction, as you all have noticed in your clients on a regular basis. One way to think about this in terms of the model is that memories are linked to how important something is. There's control, that's that blue box in the frontal lobes. A non-addicted brain may be able to resist temptation. You have a pretty good balance across these things. That's not always the case. Any of us who have tried to be on a diet means we are not always good at following through on our control mechanisms, but on average, somebody that doesn't have these issues will be able to exert control given stress, given memories. But in an addicted brain, somebody with addiction, the memories may be exaggerated, the response to stress is exaggerated, and the ability to control behavior is diminished. So this is a bit of why we think treatment is so essential. But I hope what I've described for you, even though I've emphasized some of the neurobiology, it's all about learned behavior. It's all about environmental factors. So there are ways to think through the social context, the behavior, in combination with the biology as we want to plan and address treatment needs. Okay, that's my background. Now we're going to focus a little bit on some new treatments, and then I'll wrap up and have time for a little bit of discussion, I hope, with you. We've learned through clinical studies that there are a number of interventions that have been used frequently that are not effective. Incarceration by itself does not change drug-using behavior. The boot camp models that were popular quite a number of years ago sounded pretty good. Scared straight, those kind of things, as a prevention approach related to that, sounded like a reasonable approach. The evidence is very clear that they are either ineffective and occasionally iatrogenic in terms of actually causing a worsening of symptoms. The good news is there are a number of approaches that have been proven to be effective, whether that's as broad as community and drug court models, motivational interviewing, cognitive behavioral therapy, residential treatment for those that require and qualify for that level of care. Those have plenty of evidence to suggest that they are effective. There are multiple promising approaches, and there's some where there's research needed, but I'm really quite interested in them. I've been very interested in police referrals to treatment, whether that's the King County lead model. There's some variations on that being explored right near where I live in Montgomery County, Maryland, that are intriguing. And we'll end on this. Where can you intervene? But I think that's what I'm always excited about is you all and others are constantly innovating. And that actually is my business. We're in the testing innovation business. So when you have a good idea that can address, for me, it has to somehow address the substance use issues in a criminal justice population. But if you have those, let me know, and we'll try to work with you on research grant support for testing some of those ideas. So some of them, just going back to that model, if you want to treat the addictive brain, I just have a couple of examples for you. We might want to increase the rewarding value of a non-drug reinforcer. Okay, what does that mean? Well, one example is contingency management. This is the process using typically vouchers for small prizes. It started out, the first studies were with cash payments, but that's not acceptable in most treatment programs. So they are using other forms of price-based voucher systems. It's not very expensive, and it turns out that you can enhance how long people will stay off methamphetamine, in this one example. And the longer you continue the intervention, if you do it for a month, you have a reasonably positive outcome. When you continue it for several months, you have better outcomes. It doesn't seem to last very long once you stop it, but it's kind of, some people think it's counterintuitive. You mean drug users can be motivated by something else not to use drugs? Yeah, we are testing them regularly, so you're catching them, and it's a fair, even-handed approach, and they get rewarded if they're not, and they will respond to rewards just like anybody else will. We can decrease the rewarding value of drugs. Now, one way we do this is with medications that block the effects of drugs. This is going to be true for opioids. I don't have blocking agents. I really don't have any medications for the stimulants, for cocaine or methamphetamine. But for opioids, we do have a couple, and I'll go into that in a little more detail. But this is one of the original studies looking at different dosages of the long-acting blocking agent. The trade name is Vivitrol. The chemical is naltrexone. And it showed that individuals, particularly those on the highest monthly dose, did pretty well. In this case, it was a 4-month study. They were much more likely to be abstinent. Those who were on the placebo, who got an injection that had no blocking medication in it, didn't block the opiate receptors in the brain, all of them relapsed by the end of 4 months. Of those that got the active medication, most of them were abstinent. I'm sort of intrigued that you still had about 40% who were using, so that either tells you that the drug wasn't effective, or they weren't taking it continuously, or that the pattern of behavior was so compelling that even if they weren't getting high from it, they were still using. And that's certainly possible in some of our patients. But that's a huge improvement. I mean, I'm thrilled when I see 60% versus 0% as a response. That's terrific. This was done just recently, as about a week ago. A paper was released in the New England Journal of Medicine that compared the use of this long-acting opioid blocking agent in parolees and probationers. And it compared the addition of this, so extended release naltrexone, the Vivitrol injections, compared to usual treatment. And this is the probability of not using drugs. So a separation between these lines is a positive effect, and you want to remain up towards the top if you can. If a straight line across the top would mean they are abstinent the entire time of the study. So even when they're in the study protocol, some of them do relapse, but it's a much better outcome when they're on the medication than not. This is a potentially very valuable tool for criminal justice settings. And it's quite a large study, so done in 5 different settings in about 300 subjects. So that was a very impressive study. We can also focus on increasing control over drives and behavior. Here's one that comes out of drug courts that I think is a wonderful study by Doug Marlowe and colleagues. I'm sure you all know him. What he did was he looked at how often should drug court participants be seen in the courts. Being seen in courts is expensive, so this has some economic aspects to it as well. But he stratified, based on a risk profile, the offenders into 2 different groups, either low risk or high risk. Those who were, and then he stratified them a second way into 2 different levels of supervision. Some were seen about every 2 weeks in the drug courts, and some were seen more on an almost as needed basis, but typically every couple of months. What they found was that the low-risk individuals, it really didn't matter how often you see them, they did reasonably well. They were abstinent 50 to 70% of the time. The high-risk individuals, seen frequently, did pretty well. The high-risk individuals that weren't seen very often did really poorly. So that's an example of how we can shape the environment to provide greater social interactions and greater supervision can change the outcomes here. Very important. Now, I focused a little bit on medications already, and I'll just remind you a little bit of the background of treatment for the opioids, because this has been such an important target for us lately, that we have 3 medications for opioids: methadone, buprenorphine, which is also called Suboxone or Subutex. Those are the trade names. Buprenorphine's the chemical. Or the blocking agents, naltrexone, which comes in a pill, so a daily form, or the injection that's taken about once a month. What's the difference between these? Well, I've been using the term antagonist for naltrexone. That's a blocking agent. So what it means is, think of the brain as having receptors for opium, for opiates. So that's kind of like a lock, a keyhole in a lock. And for the brain to have an action, opium or morphine or the drugs in that category come along like a key, are put in the lock and turn it, and the door opens wide. With a wide open door, a lot of activity can happen. A lot of chemicals can flow through. A blocking agent is like a dummy key that goes in there and doesn't turn. And so if other keys come along and active morphine comes in, they can't get in the lock. It's blocked from them. That's actually pretty close to the way we think these things work, as a full block. And so the door is closed and doesn't open. Now, methadone is a full agonist. So that's a key, just like opium, just like heroin. It's in the same category, so it does produce full activation. Well, that's a little puzzling. Why are we giving something that's a potential intoxicant and an active agent to somebody who has drug addiction? Well, we are doing that because of the clinical trials that show the potential benefits. Well, how would that work? It works because when you take it on a regular basis, and it has to be taken regularly in an inadequate dose, you produce tolerance. So the brain gets so used to having this opiate on board, that if additional opiates are used, so that means if somebody injects heroin or snorts some oxycodone or something similar, they don't feel anything because they are so used to it, their body is so adjusted to it from the regular dosages of methadone that they don't get any additional intoxication from the drug they might have taken on the side. That means that they are able to turn their lives around, able to hold jobs, able to function, able to be in recovery because they have a stable brain situation. Is it an ideal treatment? Of course not. I want treatments that cure these conditions. But I'm thrilled as a physician to have a treatment that will help somebody function better and really turn their lives around, particularly when the alternative is often overdose and death, or many, many problems related to addiction. That part is quite clear. So even if I'm not thrilled about it, I have lots of evidence to show the improved outcomes. Now, buprenorphine's kind of in the middle. It's a very interesting medication. It's a key. So it has some activation. The key turns, the door opens, doesn't open all the way. It only opens halfway. That's intriguing. It means that if somebody is acutely high on heroin or another opiate, and you give them buprenorphine, you actually put them in withdrawal. The door went from fully open to half open. That means they start feeling miserable and very uncomfortable. On the other hand, if they're already in withdrawal, the drugs are out of their the drugs of abuse are out of their system, and you add buprenorphine, it actually opens it and relieves the withdrawal symptoms. So it's an interesting medication because of its partial activity. It means it's inherently slightly safer. You can still overdose on buprenorphine. There can still be abuse and problems with it. So it's certainly not a panacea, but it has some advantages. It all has a practical advantage in that it's allowed to be prescribed in general medical practices, unlike methadone that has to be prescribed for addiction in a special opioid treatment program. All right, that's your opiate medications 101. Providing these medications can save lives. That's what this showed us in Baltimore, that when they expanded methadone access and when they added buprenorphine, they had many fewer heroin overdoses. So these are life-saving medications. We know from this wonderful study in Baltimore that when methadone was well, let me walk you through the study. These were individuals coming back into Baltimore after long-term incarceration, individuals with a history of mostly heroin addiction. They weren't at risk of withdrawal because, as far as we know, they mostly weren't using drugs while they were incarcerated, and they'd been incarcerated for an extended period of time. But the idea was, well, they're at risk when they go back to the community for relapse. Very high risk. We know that. So Tim Kinlock and colleagues put them in 3 different groups. Some were started on methadone before release. Some were really actively encouraged to go to a methadone program when they were released. An appointment was made and they were shown where it was. They scheduled an appointment for them, so active referral. And the third was they were told where the programs were and encouraged, more of our typical level of care. What they found was that when methadone was started before release, they were much more likely to remain in treatment. Well, that's not so surprising. You already started and they've been on it for 6 weeks. They are really motivated to continue it. But again, that's somewhat positive outcome. More important, they were much less likely to be using heroin or other opioids during the follow-up period. And this was a 6-month follow-up, and this has been up to at least a year as how long as their study went, that the drug use outcomes were improved. So starting methadone engages people better in treatment, and it may allow them to have a better outcome in the long run. They found, at least at the 6-month basis, a suggestion that those who were actively started on the methadone had less crime. This has not been as clear a finding in the long-term outcomes, but it's at least a suggestion that the combination, that providing good treatment can both improve the drug outcomes. That's frankly my main interest. I'm the addiction person. But it also seems to help their criminal outcomes. And that's sort of the principle behind combining public health and public safety approaches. Jody Rich in Rhode Island did a national study looking at, it's typical that when people are incarcerated, that many of them have their patients who are in a methadone program and commit a crime may get incarcerated, and their methadone will either be stopped or continued. It turns out that when you stop the methadone, even during a relatively short incarceration, and they go through withdrawal, they are much less likely to re-engage in treatment after release. So if you want to keep somebody stable on their treatment, it's essential that if they were on treatment, even if you aren't that interested in them starting treatment now, if they were on it before, there's a clear lesson that the outcomes will be improved if you keep it going during incarceration so they can continue it after release. Now, I highlighted for you the opioid epidemic, And I'm just going to mention this. It's a little unrelated to the rest of my talk, but it's such an important topic that I want to highlight it here, is the provision of naloxone and Narcan for overdose prevention. That we worked with a company called Adapt to prove that an intranasal spray formulation can be just as effective as what would happen in an emergency department in terms of an injection of Narcan to reverse an overdose. That's an essential tool for all of your clients who are at risk, who are heroin and opioid users, should have this with them at all times, either for themselves or from people around them. It's not abusable by itself, and it can save their lives and others. Now, the last thing I'm going to mention, then I'll stop, is that treatment has to last long enough to produce changes. I hope you've gotten from what I've suggested is that drug addiction is a learned process. It's the formation of memories because of repeated activities over and over, and it's the establishment of those as fixed patterns of behavior. Well, to unlearn those things takes a lot of time. So this landmark study out of Delaware showed that when treatment in prison was combined with what he calls aftercare, but was therapeutic community during work release, the combination of the two produced much better outcomes in terms of drug-free follow-up and arrest-free follow-up. So that's, I hope, a hopeful lesson, but one that is unfortunately all too rare in our criminal justice and treatment systems. Thank you very much. We started a little late, so I hope I have time for a few questions.
Hi. So I'm visiting from the UK, and I've observed some differences in the way drug treatment is done across the two countries. And one of the things I've observed is it seems to be much more common here to use 12-step programs as part of a drug treatment program. I don't know much about the evidence base on 12-step programs. Is there anything you can fill me in on?
Well, there's certainly the 12-step programs are the mainstay of community support and of recovery support services. They can be life-saving in terms of providing a recovery environment. It's not treatment, it's a recovery support service. The evidence is very strong when it comes to alcoholism, that it can be an extraordinarily life-saving approach. It's not quite as clear when it comes to the illicit drugs. It's certainly recommended for many individuals, and there are a lot of people that seem to benefit quite terrifically from it. But it does not take the place or a substitute for formal treatment. It's a combination of the two.
It's obviously English hour at this point about drugs. I just wondered if
it's truly an international conference, isn't it?
Are there kind of genetic effects on the children of people who have had themselves brain disease as a result of addiction, or indeed even things like brain injury? Does it make an effect on the genes of their children, or is it purely environmental?
Well, it's a very interesting question. We certainly know that these things run in families. Yeah. Having a parent who has alcoholism or another drug addiction makes the individual more likely to express it. We don't quite know all the genes involved, so I can tell you how much of it's genetic from doing large-scale family and twin studies, but I don't know specifically what genes. There's some both older literature and then some very new literature to suggest that drug exposure might actually itself be toxic for the genes, and so might produce some behavioral changes in the offspring over and above their underlying genetic structure. It's not a major effect, but it's fascinating to me as a scientist because it's sort of counterintuitive to what I was taught. That I was taught that the sperm and ova strip away all the extra material and it's just the genes that combine. But it turns out that there may be some imprinting from environmental exposures, like drugs are an environmental exposure. There may be some intergenerational transmission that's beyond just the genes, and that's we're learning about that right now. There are people like Yasmin Hurd at Mount Sinai And Ted Cicero at Washington University in St. Louis are some of the folks that have studied this over the last years. And we're trying to, some of it is that I still have to twist my brain to understand it because it's not the way we think of inheritance, but it is possible. Yeah, one more question back there, if we could. There's a break after this, and I'm going to stick around, so please approach me if you have questions. What I'm always interested in is how can we work together to improve the outcomes of the clients that you take care of and the patients that I take care of, because it is truly by working together that we'll have the biggest impact. Good question?
Can you comment on the use of treatment accompanying the use of the antagonist drugs? Is it required? You've put up slides here that show that the drugs work, but can it be done in a setting where they just receive the drugs and they're not also receiving treatment? Or anyway, if you could comment on that.
Well, there's a tremendous question about how much treatment is needed, what level of care. The short answer is we don't know what the minimum is. We do know that for most individuals, almost all these studies are done with a baseline treatment being provided. So behavioral treatments, support services, group psychotherapy, individual therapy would be the very typical interventions that are provided. So the studies would be the combination of those baseline psychosocial treatments plus medications. They are really not studied much all by themselves, and that makes sense. Even though the medications can be a tremendously important tool in moving towards recovery, these are complicated learned behaviors. And the patients that we take care of have a whole lot more than just the drugs as part of their behavioral repertoire. We need to be thinking about their social interactions, their family interactions, their psychological health. All those things need to be attended to, or the risk of relapse is extraordinarily high. So no one would recommend the medications by themselves. At the same time, exactly how much and what form of additional treatment you need is not quite established. So we're not out of the research business yet.